Alright, so first thing is your head tilt chin lift. This is used for a patient that doesn't have a suspected spinal cord injury. One hand on the forehead, two fingers on the lower bony part of the jaw, and we want to lift and tilt the head back. Head tilt chin lift. This allows us then to see the airway. If there's something in there, we'd have to suction. So again, head tilt chin lift, one hand on the head, forehead, two fingers under the jawbone. We're going to tilt and lift the head back, head tilt chin lift, so we can open the airway. This draws the tongue away from the back of the oropharynx. Not suspected spinal cord injury. Now if we have somebody that has maybe a spinal cord injury and we need to keep the head in line, we would want to use what's called a modified jaw thrust. This elevates the lower jawbone, pulls the tongue away from the back of the throat. We put our palms or thumbs on the zygomatic arch here, on the cheekbones. Fingers just under the lower bony mandible surface of the jawbone here, and we're going to lift upwards, displacing the jawbone. Modified jaw thrust. We can also do this from the front. Modified jaw thrust. This is for a suspected spinal cord injury. We want to draw the tongue away from the back of the throat so that we don't have any snoring type respirations. Now when we have to introduce something into the oral cavity, such as an OPA or a suction rigid tip, we would want to use either a cross finger technique to open the airway so we can introduce something in there, or we use a tongue jaw lift so that we open this airway so that we can place things in there. One of the airways that we can put in there is an OPA or oropharyngeal airway. We measure from the corner of the jaw to the tip of the earlobe by the angle of the jaw. Once that's measured out, we go ahead and use the tongue jaw lift because it gives us more purchase so that we can see more. We put in an OPA 90 degrees or 180 degrees and rotate that down until it goes behind the tongue and rests flatly against the flange, against the lips. This is only indicated if the person does not have a gag reflex. If they have a gag reflex, we'll take this out. If they have a gag reflex and they still have a airway issue where the tongue is in the back of the throat and they're having snoring respirations, we use an nasopharyngeal airway, nasal trumpet. This goes into the nose. We measure from the tip of the nose to the tip of the earlobe or the angle of the jawbone. Lubricate this with a non-soluble, waterable soluble lubricant, and we're going to plug the nose. Usually we go into the right ear because the right ear is much larger and we want to use the bevel towards the septum. Plug the nose. We go ahead and introduce it and gently rotate this backwards as we go all the way up to the flange. Now if the person gets stuck, we don't want to shove it or force it down. This can cause an epistaxis, so complication is epistaxis, or that we can't pass it down. If for some reason we've opened the airway and we hear now gurgling sounds and we can see vomitus in there, we can use what's called a VVAC. This is a hand or manual suction device. This setting with the flip or flap forward is an adult setting where we see we can suction a lot through this canister, or we push this backwards and now this is less volume for pediatric setting, so there's less suction. We do a head tilt chin lift. We see that there's something in there. Tongue jaw lift. Take our VVAC, only line of sight, and we suction and get all of the contents out. 10 seconds, and then we want to try to reoxygenate our patient. If this manual device is not around, then we can use what's more of a mechanical or battery powered or wall mounted suction device. This may have a perforated opening on the top so that we can cover it, or we'd have to kink the tubing. Again, line of sight, we see something in there. You do the head tilt chin lift, this tongue jaw lift. We kink the tubing. We go ahead and place it in there. Line of sight where we can see. We let go of the suction. We suction everything out for about 10 seconds. Take this out and oxygenate our patient again. Okay, let's go ahead and stop right there.